Dear colleagues, ladies and gentlemen, welcome to this live webinar. I'm Professor Roxy Senior from London, UK. I'm working as Professor of Cardiology and Director of Echo Lab at the Royal Brompton Hospital and Imperial College London. So today's webinar focuses on protocols and practical tips for contrast echo examination. As we know, contrast use has improved the feasibility of stress echo to nearly 99%. It has improved reproducibility, and also it has improved reader confidence. It further provides perfusion without the burden of radiation, unlike other technology. I have the pleasure to conduct this live session with Professor Mark Monaghan from King's College in London, UK. So Professor Monaghan has extensive experience in the field of stress echo and contrast. During this interactive webinar, we will deal with contrast protocols, mode of delivery for wall motion assessment with various stress modalities, protocol for perfusion assessment, and its usefulness. These will be discussed with reference to guidelines. The format of the webinar includes several multiple choice questions which will be presented during the presentation. Please take this opportunity to test your knowledge. Your vote, of course, is anonymous. During the 60-minute session, you can also send your questions using question and answer section. Professor Monaghan and myself will address your questions during the webinar. So now I'm going to hand this over to Mark. Mark, it's all yours now.
Thank you, Roxy. Well, as you've said during your introduction, we're going to discuss a technique that's pretty close to all our hearts and one that you and I work with very, very regularly. But first of all, I need to get my disclosures out of the way, which you can see on that slide there. So let's get started straight away with an example. Now, this isn't a stress echo, but I think it illustrates very nicely how you can use contrast to really rescue an image. I mean, I think you'd be hard put to even say there's a heart there on that image on the left-hand side. But once we turn on a contrast-specific imaging modality and we give it administration of an ultrasound contrast agent, then we can see endocardial definition very clearly. We can actually see thrombus in the apex of the ventricle, and it really has transformed a non-diagnostic image into a diagnostic image. Now, of course, good endocardial definition is absolutely critical when we're doing stress echocardiography. And I like to think of it as looking at the dark side of the moon. When we add a contrast agent, we can take a stress echo image of the type I showed you and make it interpretable. Now, you and I both worked on these evidence-based recommendations produced by the European Association. In fact, you led the group on this. And part of the presentation that we're going to be discussing today is based upon these recommendations and looking at how they can be practically applied. So I guess the first thing that we need to consider is what are the indications for using contrast during stress echocardiography? And the basic indication is very simple. It's when two or more endocardial border contiguous segments are not well visualized. And the reason we do this is to obtain a diagnostic assessment of segmental wall motion and thickening, which is very important, both at rest and stress, and to increase the proportion of diagnostic studies and to increase reader confidence in our interpretation. Now, I often get asked, well, what about the risk of using contrast agents? We all know that they bring benefit, but what's the risk? Well, I think these data are very, very helpful because it sets it in context. So you look at the mortality risk of contrast echo compared to other common diagnostic techniques, such as myocardial scintigraphy, exercise ECG, and coronary arteriography. And actually, you can see that it's significantly less with contrast echo. And yet, as we'll discuss over the next hour, the benefits of using contrast echo are really very, very significant. So how do we actually give the contrast agent? Well, basically, we can do this using either a bolus or an infusion. If you're using a bolus, we're only going to be giving a very small volume, so 1 ml syringe is usually sufficient. And the advantage of doing this type of administration is that it's very easy and it's cheaper because you end up using a very limited amount of contrast agent. But the problem is that the concentration of the contrast in the heart and in the LV cavity in particular is changing constantly, builds up to a peak and then it decays away. So it's never, or at least it's only at the optimum concentration for a very brief period of time. That makes it less suitable for doing perfusion imaging, and I know we haven't touched on that yet, but we certainly will be later on in this webinar. And also it makes it less suitable for doing 3D echo, where again we want a constant contrast concentration. Now on the right-hand side you can see an infusion pump which has specifically been designed by Bracco in this case for delivering IV contrast, in that it keeps the contrast agitated and prevents it settling out, and then using a remote control you can actually dial in very precisely the contrast infusion rate that you want. So it's very, very controllable. And that allows you to avoid attenuation and other artifacts which can beset contrast administration. And because the concentration is constant, as I said, you can do perfusion and 3D echo. But you do end up using more contrast, which adds to the expense. And also you've got the cost of the pump and the IV giving set as well. So doing it this way undoubtedly adds to the cost of the procedure, though in the overall scheme of things, I think that's relatively low. So let's look at the contrast imaging protocol we use at King's, and I suspect that this is fairly common, and it certainly was in our recommendations. So you should start off using standard 2D harmonic imaging to adjust your scan planes and to actually make sure you need to use contrast. So we need to check how many segments we can see and how many we can't see. And then you'd activate the contrast-specific preset on your machine, and all contemporary echo machines basically have an LVO mode, which is a higher mechanical index mode. It's still relatively low compared to conventional imaging, and then a low MI mode, which we use for when we're doing perfusion imaging. Then you adjust the focus, gain, and sector width appropriately, and we'll talk a bit more about that later on. And then you administer your contrast, either through a bolus, as I described, in which case you'd probably want to give it in 0.3 mil boluses, or if you're giving a constant infusion and if you're using an agent such as Sonoview, then an infusion rate of about 0.8 to 0.9 mils per minute is usually adequate if you're doing perfusion imaging. And then wait for full LV opacification to occur and adjust your contrast and gain if necessary to obtain even opacification of the whole LV cavity. And then we'd acquire our baseline images. So start off with the apical views, the 4-chamber, 2-chamber and 3-chamber, and you can admit the short axis and long axis parasternal views if you get attenuation from the right ventricle. And don't forget, of course, the contrast concentration in the RV is going to be higher, so if that's between you and the LV cavity or the transducer in the LV cavity, you may get attenuation. And then acquire digital loops, backing up on videotape if you need to. So if you're doing flash replenishment imaging, now you may not know what that is, but believe me, at the end of this seminar you should do, then you're going to use a low MI setting on the machine, and you want to acquire over longer beat loops, because as I'll describe, you're going to flash the image to destroy the contrast and then watch it replenish into the myocardium over subsequent cardiac cycles. So you need a longer loop in order to be able to do that. Then you'd adjust the contrast infusion and gain until you achieve a steady state and myocardial opacification is achieved. And then we use approximately 7 flash frames. These are the frames that I mentioned that destroy the contrast agent at a higher MI. So this is the mechanical index that we'd use for conventional imaging. And adjust it during rest to ensure the contrast clears from the myocardium. So again, adjusting the gain and also the contrast infusion rate. So here are the protocols that we would use for dobutamine stress echo for reversible ischemia and myocardial viability. Now, a standard protocol using dobutamine goes up from 0 in 3-minute stages until we administer 40 micrograms per kilogram per minute if necessary. And also, if necessary, we can give atropine to actually make sure that we achieve a target heart rate. Now, conventionally, we would image at baseline at a relatively low dose, say about 20 micrograms per kilogram per minute for reversible ischemia, as you're approaching peak and then at peak. And then I would start the contrast infusion approximately 1 minute before you want to start imaging, because you need it to equilibrize and achieve a constant level within the LV before you start imaging. Now, a myocardial viability protocol is defined by the fact that actually we go to a lower dose, usually about 20 micrograms per kilogram per minute, and the stages are longer. They're 5-minute stages rather than 3-minute stages, so that you get the opportunity to see contractile reserve in the myocardium before ischemia occurs. And again, we would image at baseline and at each stage, low dose, intermediate, and then our high dose, which again is 20 micrograms per kilogram per minute. And again, I would start the contrast about 1 minute before we start imaging. Now, if you're doing exercise echo, then you would normally be using a bolus. So you do your bolus injection at baseline as normal. But for peak exercise imaging, what I like to do is to give a 1 ml IV bolus about 1 minute before peak exercise is reached. And then by the time the patient gets off the treadmill or off the bike, onto the couch, lay down, and you've got the imaging in place, then usually the contrast is equilibrized and you can get nice images at peak stress echo. So here's an example, a typical stress echo referral. I have to say that before using contrast, when I would look at these baseline images on the left-hand side, I would have said this was an impossible technique to use in this patient. But as you can see, with the right-hand images, they're not perfect, but they're easily diagnostic. We can see endocardial wall motion and thickening quite adequately, and therefore we very, very rarely now would turn down a patient for stress echo on image quality, because contrast, as you said in your introduction, rescues them all, and we can use it in 99% of cases. Now, these are one of the many, many studies that have been published using the advantage of, illustrating the advantage of using contrast during stress echo. This is the optimized trial from Bill Zogby's group in Texas. As you can see here, that if we look at the percentage of segments that are visualized without contrast and with contrast, both at rest and at peak stress, there's a significant increment when contrast is used. And that translates into increased confidence in terms of interpretation. So you can see that the number of segments or number of patients where the readers had a high confidence for their diagnostic interpretation was much, much higher when contrast was used rather than when it wasn't used. And of course the converse was when it was low. So they had much higher or much less confidence when contrast wasn't used. And also, the agreement between readers was much higher and when contrast was used. So if you take patients with poor baseline image quality, then contrast made a significant difference in terms of the agreement between readers. Whereas, of course, as you might expect, if the contrast, if the baseline image quality was good, then contrast really didn't have much impact. And I think that underlines the kind of patients in which we would use contrast. And that's highlighted here. So if we look at the accuracy of stress echo compared to coronary angiography in relation to the number of segments visualized, you can see that when there were more than 2 segments not visualized and contrast was used, it significantly increased the accuracy. Whereas at baseline without contrast, when you saw all segments, needless to say, contrast really didn't add much. Okay, Roxy, I think I've been doing quite a bit of talking now, and I think it's time to let our audience answer some questions. So we've got the first of the multiple choice questions for you to look at, and these take us back to the guidelines, and it's really quite an easy one. So you have the opportunity here, and there's 4 choices. So when should contrast be used in not just a stress echo case, but an LVO case? Should it be when the endocardial border of any segment is not seen clearly, when the border of at least 2 contiguous segments are not seen clearly, or vote 3, when the border of at least 3 contiguous segments are not seen clearly, or vote 4, when the border of at least 4 contiguous segments are not seen clearly? So Roxy, they have some time to do that. How long have they got?
Yes, so they've got 1 minute
to
do this. So while you're looking at the answers and getting to the answering those questions, let me ask you a practical question, Mark, now when you use a contrast protocol during stress echo, in terms of MI setting, what would you recommend in terms of doing your day-to-day stress echo?
Okay, so as I said, you have basically 2 choices on most machines. You've got the low MI setting, which you can use for myocardial contrast, for myocardial perfusion setting, or you have what's called an LVO setting, which is a slightly higher setting. Now, my personal preference for routine stress echocardiography when I'm reading wall motion and thickening is to use the LVO setting. And the reason I like that is that the myocardium is generally black, so it makes it easy to see, and also the frame rate is higher. So when you're doing a dobutamine stress echo with high heart rates, then it makes it easier. And what we tend to do is after we finished our wall motion analysis, then we press a button, and that's all it is. We just press the button and the preset comes up for the low MI setting, which is allows us to look at myocardial perfusion over a longer loop. So we actually use both methods. I know you do it slightly differently.
Yes, so we tend to do both simultaneously in low MI setting, where we can assess perfusion and function together straight away in terms of volume and wall motion. But I gather it doesn't make a lot of difference in terms of diagnosis, whatever setting you use. But yes, it should generally be towards the low MI in order to prevent destruction of the contrast. Okay, I think we've got the results here for the question that has been asked. And 72% had got it right.
Okay. But there were a few that clearly weren't paying attention. Okay, well, let's see if you can do better on the next one that comes up.
Okay, yes. I mean, according to the guidelines, it is 2 or more segments for those who haven't answered it correctly. Okay, so we'll move on now.
Okay, yeah. All right. So I'm not going to ask you questions on this one, but that doesn't mean you shouldn't be paying attention. I want to show you an example of a viability study now. And as I said at the beginning, the protocol for this is we would start off, and you'll see this at the top here, this is at baseline, this is at 5, 10 and 20 micrograms per kilogram per minute of dobutamine. And what we're looking for is evidence of contractile reserve. And in this particular setting, the contrast is allowing us to see the endocardial border. And we do really need to look at it very closely when we're looking for what may be very small increments in contractility. So when you look at this apical 4-chamber view, you can see that the apex is dilated. Actually, the myocardium here looks very, very thin, which gives us a clue. And it's akinetic and really shows very little evidence of improvement in function in throughout any of the stages. And you can see the same thing here. This is the 2-chamber view. So again, you can see this anterapical area, which is really not contracting and doesn't improve during the various low-dose stress stages. And the same picture here in the 3-chamber view. So this is an example of a patient where there really is no viability in the anterapical segments. The other segments are full thickness, they contract well, they increase in their contractility during the stress stages, but the apex and the anterapical segments don't. And so they are non-viable. Now here's a slightly more complex example, and in the interest of time, I'm just going to show the 4-chamber view, but this is a very, very important example because again, this is a patient where there is a wall motion abnormality at the apex. And you can see in the baseline views here that there is very severe apical hypokinesis, if not almost akinesis. And then when you go on to the low dose, you can see that actually improves a bit and increases in thickening. But by the time we get on to intermediate and certainly peak dose, this has become akinetic again. So it started off moving very, very poorly, improves, and then deteriorates again. And this is what we call a biphasic response. And this is really very, very important because it indicates myocardial segments which are at jeopardy and would really benefit from revascularization. And there's some excellent data to show that if these patients are revascularized, they do very, very well. But more importantly, if they're not, they do extremely poorly. So it's a very, very important finding on a stress echo report. And there's no doubt that contrast helps you identify these subtle changes in wall motion. So it's time for you to concentrate again because this case forms the next multiple choice question. So it's a 79-year-old man referred for stress echo because of shortness of breath on exertion, which was thought to possibly be an angina equivalent. And the format is going to be the same as the previous ones I showed you. So it starts off on the low dose, on the baseline, low dose, intermediate, and peak at the bottom right. And this is the apical 4-chamber view. So have a good look at that. And then we'll move on. Here is the 2-chamber view. Again, peak is on the bottom right, and the baseline is at the top left. A short axis view. Actually, just as an incidental finding, you can see here the contrast level is really not quite high enough, and that baseline image. It's just about good enough to see the endocardial border, but it's not quite as high as I would like it. And here we've got a little bit of attenuation. So just a couple of examples of some artifacts there that are not completely spoiling the image quality, but are just subtly present. And here finally is the long axis view. Okay, so imagine you've just done this stress echo and you've got to report it now. So choice number 1 is, do you think this is normal? Choice number 2, is it LAD disease? 3, right coronary disease. 4, left circumflex disease. 5, is it a combination of LAD and right coronary? or 6, is it 3-vessel disease? So again, they have a minute, is that right, Roxy?
That's right. So while they are searching for their answers, we'll have another question answer session. So how do you ensure in your practice, when you do stress echo, that that LVO pacification is uniform and that there are no attenuation artifacts? Because as we all know, that with stress echo, we need to see every segment of the heart in order to be sure that it's normal.
Yes.
So how do you deal with the situation of attenuation artifacts appearing or not getting proper LVO pacification?
Well, I mean, the most important thing is the contrast administration and the contrast level. I mean, obviously the machine settings have relevance as well, but you've got to get the contrast level, first of all, correct. And of course, that's much easier to do if you're doing it with an infusion, because you can change it and see the effects of it. So if it turns out that, as I showed you previously in that short axis view, that the contrast looks, very low level, looks very low in the LV, then you need to boost it. If, on the other hand, you can see that the contrast is very bright near the transducer and then you've got shadowing beneath it, then you need to reduce the amount of contrast you've got because it's causing attenuation. So once you've got the contrast level right, then I would adjust the gains, including the overall gain and the TGC setting, so that it looks uniform over the whole LV cavity. And we'll talk a little bit later about shadowing and things, but sometimes you need to modify your transducer position to try and avoid rib shadows and pupillary muscles and other things that can cause shadows. It comes down to practice and experience, but it is possible to get nice images.
Yeah, absolutely. I think that practice makes everybody perfect. So I think we've got some answers here.
It's a mixed bag of results, isn't it?
It's an extremely mixed bag of results. So, Mark, how do you explain that with contrast these people are not getting it right?
Well, I mean, I don't think it's the contrast that's at fault here. I think it's one of the very, very basic rules of stress echocardiography, that a normal response to the left ventricle to stress echocardiography is for it to get smaller and for the volume to decrease. And if that doesn't happen, then that's usually a pretty good indication of widespread disease. And so let's actually have a look at what happened in this particular case. So I'll tell you the answer. First of all, this was widespread disease in this patient. It was 3-vessel disease, which actually only 18% of people got correct. And this is the coronary angiogram that you can see in this patient here. So though it's not playing, you can still see that they're pretty tatty vessels and there's disease in all of them. So let's just review the images again. So if you, for example, you just look at this 4-chamber view, and really all the information is in there. If you compare this peak image to either the baseline or indeed the low dose, you can see the LV cavity is bigger, and particularly in systole. So you've actually got the diagnosis on that one image, but it's replicated that information in all the other images as well. You can see, I know why people thought it was LAD disease, because you can see, in fact, and this may well be more severe, it may actually be left main, because you can see that there's really, really widespread wall motion abnormality up there in the anterior wall. And again, when you look at the short axis view, the cavity certainly hasn't got smaller and probably has got a bit bigger. Less seen, perhaps slightly less clearly seen in this long axis view, but again, this is a very, very abnormal response. All the myocardial segments are contracting poorly and the cavity has failed to decrease in volume. So it's actually, people spend a lot of time worrying about the wall motion and what's changing in that. A very simple thing. Look at the cavity volume.
Absolutely. I think that is one of the basic rules of stress echo, isn't it? First of all, look at the cavity size and then go segment by segment what's happening. So if the cavity is dilated, now you look at segments, where it is dilated, why it is dilated. So yeah, this case clearly illustrates the fact that the LV dilated after becoming smaller, clearly suggests a huge amount of myocardial ischemia and likely to be 3-vessel disease.
Yeah. Okay, I'm sorry for that, but I'm afraid they don't get any easier. Okay.
All right, we'll move on.
Now, you might wonder why I didn't put this slide in right at the beginning of the presentation, because most people, when they start talking about stress echo, they start off by showing the classical ischemic cascade you can see here. And of course, as we know, that when you increase myocardial oxygen demand in a myocardial segment that's subtended by a vessel with a critical stenosis, then the last things that happen are the patient may get chest pain or ECG changes. Earlier down the cascade, you get the wall motion abnormalities that we look for in conventional stress echo. But actually, one of the first things that happens is that myocardial perfusion becomes abnormal. And as we've already intimated, with contrast echo, we actually have the opportunity to not only look at wall motion, but to look at perfusion as well. Now, as Roxy said, in their practice at the Brompton Hospital, they use the low MI mode through all their imaging because that allows them to look at perfusion at the same time. And it doesn't really matter, but here's quite a nice example of that. So this is before we've given any contrast at all. It's a low MI mode. Actually, you take my word for it, it's an apical 4-chamber view, and here's the contrast coming to the right ventricle. It's done transpulmonary passage, and now it's nicely opacifying the left ventricle, but all the time the contrast concentration is building up in the LV and of course in the myocardium until we get to the point where now we can see the myocardium has lit up as well, and we can get an appreciation of myocardial perfusion. And of course, that can be nicely incremented into our stress protocol. And this has been demonstrated, and there's been extensive research on this, and Roxy has published quite a few papers on this, as you can see, showing that there is very, very good evidence for incorporating myocardial contrast echo within your standard contrast stress echo protocol, because it does give you incremental value. And I like this paper because although it's very old, it actually underlines very much what we saw in that ischemic cascade. This is a dog model where there were ligations or coronary stenosis produced in the LAD and the circumflex territories, but not in the right coronary territory. And it was during dobutamine stress echo where contrast was being given. And you can see that at a very early stage in dobutamine stress, we start to appreciate the perfusion abnormalities, but you can see contrast in the myocardium. And here, at the sort of intermediate stage, again, we can see the perfusion defect in the LAD and the circumflex. The right coronary is perfused well, but these perfusion abnormalities occurred before the wall motion abnormalities. And that's the key thing. And that's really one of the very, very useful things that allows us to apply it during stress echo. So here's an example. This is a patient at an intermediate stress stage. It's an apical 2-chamber view. And as I put on here, we're using the low MI setting rather than the LVO setting. And you can see the heart rate's only 113 beats per minute. So we haven't achieved peak. But if you look at this now, if you're an expert in stress echo like Roxy, you will have picked up that the inferior wall is hypokinetic. That's not completely normal. But actually, look at this in a bit more detail, and you can see that if you look at the subendocardium running around the inferior wall, notice how the myocardial opacification is less. There's a dark rim here that actually extends around the apex where it's very, very obvious, and into the anterior wall. Now, the apex and the anterior wall are contracting normally, but we can still see a subendocardial perfusion defect. And of course, when we see that in the subendocardium, that's a really strong marker of ischemia. And indeed, when this patient went on to coronary angiography, you can see there was both LAD and right coronary disease. Actually, though I haven't shown you the other views, the left circumflex was normal on the stress echo and also on coronary angiography. But the point here is to show you that you can pick up the perfusion defects at a lower stage than the wall motion abnormalities. Now, one of the other techniques that we use that I haven't talked very much about, but just briefly mentioned, is to do flash replenishment imaging. And the reason that we want to do this is we want to look at the myocardial blood flow velocity, and we can do this by firing a high intensity frame, actually about 7 to 10 frames, at the same output power that we use for conventional transthoracic imaging. And that destroys the contrast in the myocardium. So we start off at a low MI, fire a few frames at a high MI, which wipes out the contrast in the myocardium, and then we watch it replenish back into it. Now, during stress echo, when coronary blood flow is increased, it usually takes about 2 cardiac cycles for the myocardium to completely replenish. And if it takes longer than that, then that implies that the myocardial blood flow velocity is reduced, and that there may well be a critical stenosis in epicardial vessels supplying those segments. And I've sort of shown that diagrammatically there, but let's look at a real case. So this is a patient with hypertension and atypical chest pain, having a stress echo. Now, this is actually at peak stress. You can see the heart rate's high. And hopefully most of you have looked at this, even though you've seen the baseline, haven't seen the baseline images, and recognize that the lateral wall here really is very, very abnormal. That's really quite hypokinetic compared to the septum. But if you had any doubts about that, just look at what happens following the flash. You can see when the flash occurs, the whole image becomes brighter. And then notice here that the septum replenishes very, very quickly. But from this point here, at the midpoint and the apex, all the way around the lateral wall, there's very, very delayed reperfusion. So that tells us that the myocardial blood flow velocity is significantly reduced here. And here we can see exactly the same thing in the three-chamber view. Again, when the flash occurs, we've got almost instant replenishment in the anterior septum here, but from that point, you can see the cutoff point, all the way around the posterior wall, there's significant underperfusion. So again, if you weren't any doubt about the wall motion, there's no doubt that seeing the perfusion defect enhances your ability to pick this up. So no prizes for guessing that this patient actually had significant left circumflex disease. The other vessels were actually completely normal. Now, again, this has been looked at in a number of publications, and I'm just showing you one for time's sake, and this comes from Tom Porter's group in Nebraska, and Tom has done a significant amount of work on the use of myocardial contrast echo during debutamine stress. And in this paper, it really highlights exactly what I was saying, that if you look at an intermediate stage of stress, and look at the sensitivity of perfusion imaging as opposed to wall motion imaging, you can see that it's significantly higher. Even at peak stress, it's higher, although clearly we might expect more wall motion abnormalities to occur here. But sometimes, for various reasons, we don't ever make it to the peak stage stress, or we want to increase our confidence. And as you can see, that by adding contrast in and looking at myocardial perfusion, we really do have the ability to do that. Okay, so this is, I think, the last case I'm going to show you, and it really is probably the toughest of the lot. So here's a patient, of course, where stress ECG would be probably completely useless because the patient's got left bundle branch block, but she is a patient with atypical chest pain, and so she was referred for stress echo. Now, even with stress echo, I find these patients quite challenging because the left bundle branch block can lead to wall motion abnormalities at rest and during stress. So the format's the same. Baseline at the top, peak stress down here. So have a look at this and see what you make of it. So here's the short axis view. This is the three-chamber view. I'll leave that playing for a few minutes. Here's the two-chamber view. And here's the four-chamber view. Now, I know in reality you'd probably stare at these images for a little bit longer, and I certainly would in a patient with left bundle branch block because they're challenging, but we don't have that opportunity now. So I'm afraid you're going to have to vote in a second. So we actually stopped at this stage because the patient was experiencing severe stomachache, which actually was her atypical chest pain. So I want you to tell us whether you think this is normal, whether it's three-vessel disease or whether there's a disease involving the LAD, which is number 3, the circumflex, which is number 4, or the right coronary artery, which is number 5. So you can vote now.
Okay, yeah, a minute for voting. So while the voting continues, so another question of you, Mark.
Yeah.
Again, it's because it's a session on how one does contrast stress echocardiography. Especially now that you're talking about myocardial perfusion. So, as you know, we are all aware that we do see some basal perfusion defects, which may not be truly defects, or even apical defects, again, which may be pseudo defects. And this is not uncommon. So how do you decide whether it is an artifact or is it a true defect? In your practice, how do you do that?
Yeah, I mean, that is something that takes a bit of practice, but there are some basic rules to follow. So first of all, when you're looking specifically at the apex, I think it's helpful to have the focus nearer to the apex. Don't have it right down at the basal portion of the ventricle because that means that the scan lines will be narrower at the apex. They won't overlap each other. So that increases the sensitivity and also reduces destruction, which can occur by overlapping scan lines. Secondly, make sure there isn't any attenuation, because if you've got attenuation, then that can produce a pseudo defect in the more basal LV segments. Yes. And also you need to make sure there isn't any shadowing. So shadowing can occur from ribs, and it can occur from even things like papillary muscles. And it can run along the myocardium and make it look like a perfusion defect. And one of the ways of determining whether it's truly a shadow or a true perfusion defect is if it's a shadow, it'll have a linear edge to it. It'll run in a straight line. Yeah. So adjusting the gain, adjusting the contrast, adjusting the focus. And the other thing that I think is a difficult thing for people to remember, but actually works very, very well, is sometimes it's nice just to get the myocardial segments that you're interested in the middle of the image,
Yes.
where the sensitivity is higher. So if you're doing an apical 4-chamber view, start off with the septum right in the middle and then swing the transducer so the lateral wall's in the middle. And then do the same with the 2-chamber and the 3-chamber view, because the sensitivity is going to be greater in the center of the image, and there's going to be less chance that you're going to get these artifacts that you were just asking me about.
And to start off, when you do the stress echo with contrast for perfusion, we tend to keep the focus at the base, so that you get all the scan lines going down all parts of the myocardium,
Yep.
and then you move it up if there's a apical artifact.
Exactly.
Yeah.
So keep it to where the area you're interested in.
Yeah.
So, yeah.
Absolutely. Okay, I think it's time to see what's happened. Well.
Yeah.
Again, it's all over the place. 23%, 12%, 28%. Right. So, would you like to throw them out of the misery?
Yeah. Well, to be honest with you, it was a really unfair case, actually, but intentionally chosen, and this is exactly how I would have predicted you to answer it, because I would hate to be forced to interpret that particular stress echo. And MCE came to our rescue in this particular case. So let me just move on and show you the myocardial contrast images in this particular patient. And actually, even before we do the flash, you saw right at the beginning of the sequence there was contrast in here, but you can see that after the flash, it really takes a long time for the apex to reperfuse, and that extends into the lateral wall and probably the apical septum. Here is the 2-chamber view here, and again, watch what happens after the flash, and there's the flash, and really quite a persistent defect here at the apex, possibly going a bit into the anterior wall and just around then to the 2-chamber. And then here's the 3-chamber view, which is, I think, quite nice, because it shows both actually before but particularly after the flash, really delayed reperfusion around the apex into the anteroseptum and into a good deal of the posterior wall near the apex there. So in fact, when this patient was angioed, they had important disease in the LAD and reasonable moderate disease in the proximal circumflex, which actually fitted with the MCE images rather than the wall motion. Now, what I didn't tell you completely was I said we stopped the stress echo because the patient was experiencing stomach pain and said it was really uncomfortable. So we actually didn't get to peak stress. And if we'd been able to do that, then we may well have had the wall motion abnormalities.
Yes.
But MCE rescued the story for us and gave us the diagnosis.
And also, you can see from your image that there's an apical defect and your focus is towards the apex, so that's a true defect.
Yes, absolutely. Yep. Okay, so I think I'd like to show this particular paper, because again, it's one of many, and I know that you've published in this area as well, Roxy, that highlights the fact that stress echocardiography, when you're using contrast and looking at myocardial perfusion, doesn't just assist in our diagnosis of reversible ischemia, but it also gives us outcome information. And of course, that's very important these days. Everyone wants to know, well, what's the impact of our investigation in terms of predicting what's going to happen to an individual patient. And you can see here from this paper from Tom Porter that in this cohort of patients followed up for 3 years, if they had normal wall motion and normal myocardial perfusion, they did extremely well. But even if they had normal wall motion but abnormal perfusion, you can see that they did less well. So just adding in the perfusion information, even in the face of a normal conventional stress echo, that showed that they had a poorer outcome. And if both were abnormal, then it was a very, very poor outcome. So it really does add to our prognostic ability. Now, if we're doing just MCE, then actually we don't need to use dobutamine. It's easier to do this with vasodilator, because that maximizes the perfusion defect. Plus, it's a very, very quick protocol. And you can use either dipyridamole or adenosine, and you would do your baseline imaging as you would normally, and then give dipyridamole or adenosine, and then obtain your stress images. So you don't get a sequence of images, you get them at baseline and then at stress. Now, don't expect to get significant wall motion abnormalities. It really is the perfusion abnormality you're looking for. Now, again, there's been several publications on this particular technique. This is a study that Roxy and I participated in, which is a large multi-center study comparing myocardial contrast echo with dipyridamole stress against SPECT, also done with dipyridamole stress at the same sitting, where coronary angiography was the so-called gold standard. And you can see that the area under the receiver operator curve for sensitivity and specificity is identical for the two functional tests. But the difference, of course, being that nuclear is very much more expensive and exposes patients to significant ionizing radiation. So a stress echo test in this context is certainly a much preferred way to go. And I'd just like to illustrate one case from the study that Roxy and I did, and it's a very typical case. So it's a lady who had an MI previously, had exertional angina, hypertension, hyperlipidemia, and was referred for stress echo for investigation of the angina. And the format I'm going to show you is that on the left-hand side, we have the baseline image. This is the resting view, and then this is following the dipyridamole administration. So you can see that once we give the contrast, we've got nice myocardial opacification. You can see the flash imaging there. And then this is the one that's really important. So this is the stress imaging. Now look very carefully at what happens. Following the flash, you can see that we've got a persistent perfusion defect at the apex, but I think also running into the subendocardium of the septum and also down the lateral wall. Now watch what happens after flash. You can see it for 3 or 4 cardiac cycles, and slowly it fills in. Here is the two-chamber view. Again, the baseline image here. This is the resting image. Let's not focus on that. Let's look at the money image, which is this one here, which is the peak stress image. And again, look what happens after flash. It's not only the apex and the anterior wall that's affected, but look at this apical inferior wall. There you can see very nicely the perfusion defect. So I'm not showing you the three-chamber view because it doesn't really contribute anything. But actually, the core lab that read this, all 3 of the readers read an LAD defect. Now, as I showed you, and I think Roxy agrees because he's looked at this before, is actually we saw perfusion defects in all 3 coronary territories, in the lateral wall, the posterior wall, and in the inferior wall, as well as the apex and the anterior wall. And interestingly enough, when the core lab read the SPECT, all 3 readers read it as being normal. And indeed, when you look at these SPECT images, they do look relatively normal. Now, what did this patient have? Well, actually, as you can see here, the patient had significant 3-vessel disease. So it's not surprising that perhaps the SPECT was negative, because as we know that when you've got 3-vessel disease, you've got a balanced circulation, and SPECT really doesn't do very well, but actually a contrast perfusion image, which truly looks at regional perfusion, does very, very well. And here you can see the coronary angiogram in this particular patient, showing you significant disease on the left side, and the right was the same. So it's interesting to note that the recently published ESC guidelines on contrast stress echo, that it highlighted stress echo, also highlighted the importance of myocardial contrast echo. And I think this is a good endorsement of what we've been talking about, Roxy. And they point out that it adds incremental information beyond what we get from conventional stress echo when we can look at myocardial perfusion as well. So let me summarize as we come to the last section of this webinar, some of the essentials that I hope we've covered in the last 45 minutes. So contrast echo really has an absolutely essential role in patients who've got poor echo windows, and that doesn't matter whether you're doing stress or an LVO study. And at King's, we use it in at least 75% of our stress echo cases, and I think at Brompton it's probably even higher than that. When we're doing a perfusion, of course, we use it in 100% of cases. And it really adds very little time or relative cost when you think about the overall expense and time involved in performing a stress echocardiogram. It adds user confidence and accuracy to our stress echo study, and I've shown you data that proves that. And I think perfusion stress echo should be routine because there's enough evidence, and we've shown you some good clinical examples which highlight the value of it. And it will lead in the end to a faster study because it's much quicker than a conventional dobutamine stress echo, and improved accuracy. So, you know, you've nothing to lose, Roxy, by using contrast doing stress echo, and I think lots to gain.
Absolutely. So, thank you, Mark, for your illuminating presentation. There's pun intended on the word illuminating.
Yes, I know.
So now, but we've got a few questions. Now it's a question time, and the audience have been very, very active. They've
Well, they have, haven't
powered
they?
in with a lot of questions. So, let's begin. We've got some time to answer these questions. So let's take this question. Should MI be low also in diapridamol perfusion imaging?
Yes. So when we're doing diapridamol, we're actually not looking at wall motion. We are actually looking at perfusion. So in order to see the contrast within the myocardium, we do need to use the low MI setting. But as I showed you, we're going to use the flash imaging as well. So it's going to be a combination of doing the low MI imaging to look at the contrast in the myocardium, firing 7 to 10 frames in rapid sequence of high MI to clear it out, and then watching the replenishment on the low MI imaging. So most of the imaging will be done in low MI.
Absolutely, and that's what we do because you're quite right. Not only with diapridamol, with all vasodilators, where the heart rate doesn't go up that much, you don't expect any wall motion abnormality to appear because you're not actually increasing the demand.
Yes.
So we are looking just at perfusion. So absolutely. So that's very important to know. Now, just following on from this question further down, actually, one of them has asked the question, why do we need to use flash during myocardial contrast echocardiography? Can we not see perfusion defects without flash?
Well,
I mean, what is the utility of flash?
You can, and I showed an example of that, that sometimes you can see the perfusion defects, but really, when you're talking about myocardial perfusion, it's a combination of two things. It's a combination of the myocardial blood volume, and it's a combination of the myocardial blood flow rate. Now, the intensity of the contrast in the myocardium gives us part of it. That's actually directly proportional to myocardial blood flow volume. But by flashing and then looking at how quickly it replenishes, that gives us the flow rate. So by putting both bits of information together, we get it. Now, and if you really wanted to quantify perfusion, then that's what you would look at. You'd actually measure the replenishment, look at the curve, and look at the slope of the curve and the plateau. But from a clinical perspective, when you're reading these images, the most important thing, I think, is to look at how quickly it replenishes. And it's a pretty simple rule. Look at about 2 beats following the flash during peak stress, and if the myocardial segments haven't replenished by that stage, then that's an abnormal response.
Absolutely. So myocardial contrast echo, the way we do it, we're actually looking at blood volume and velocity.
Yes.
And there's been studies which have shown that because of the component of velocity that we're looking at, it is more sensitive than techniques that look at just blood volume like SPECT,
Yes, absolutely.
like MR. So flash imaging is very useful because it also increases the diagnostic accuracy of the test. Absolutely. So, so another question, very practical question. Can we use perfusion protocol during exercise stress echo protocol using bicycle?
In theory, you could. And in theory, it's possible, but it's going to be technically challenging. Particularly trying to do some of the techniques that I was talking about, where you're ready to get good perfusion images. Sometimes what you need to do is to use off-axis views and bring those myocardial segments that you want to right into the center of the image. And so, you know, if you've got a patient with a good window and a really expert echocardiographer obtaining the images, then I'm not saying it's impossible, but it's not going to work, you know, be as easy as during pharmacological stress. And where it really works best, as we've discussed, is during vasodilated stress. That's where you can be confident that the technique is going to work best.
Yes, and during bicycle, of course, it's very much like pharmacological stress. And with bicycle, the patient is lying there, and you can get the images at peak stress. On treadmill, it may be slightly difficult because the patient is coming up. But with bicycle, we have actually published a recent data on this, looking at exercise perfusion. It's just come out in JACE last year.
Yeah.
And it works, but you have to be very quick, you have to be fast, and and get the images very quickly in the correct sequence. So, but I think the lesson is to actually develop the perfusion technique with dobutamine or vasodilator and then move on to the next level.
Yeah, absolutely. Absolutely.
Okay, this is again a very practical question. What are the contraindications for contrast echocardiography?
Well, one of the main contraindications are if patients have a history of allergic responses. And that it varies from contrast agent to contrast agent. But, you know, for example, with Sonoview, you would not perhaps want to give it to patients who've got a history of allergies to sulfur-based products. Or with some of the other contrast agents that contain albumin, you may not want to give it to patients who have known allergies to eggs, for example. And then, you know, there's some relative contraindications. You're not supposed to give it to patients who've got known intracardiac shunts. You're not supposed to give it during pregnancy. It used to be contraindicated in pediatric cases, but I know that there's quite a lot of data now that it's been used successfully during pediatric cases. And some of the contraindications have actually been removed. So, for example, it used to be that you weren't supposed to give contrast agents if a patient had had a recent acute event. Well, that now has been tailored down, and it's possible to use contrast agents more recently post-MI, for example. And we often end up doing contrast echoes to look for LV thrombus in patients who've had a myocardial infarct, and we used to have to wait a week. Now we can do it much quicker.
Absolutely. So I think there's very little contraindications as far as contrast is concerned now. I think the only major contraindication that remains is the right to left shunt. Is that right? And there's, yeah. Okay. So now moving on. There's quite a few questions that's come up now. Okay.
There are a lot, aren't there?
So the question here is to do with perfusion. I mean, many are very interested in perfusion aspect of the whole situation. So shall I do perfusion at baseline? And if abnormal, how should I interpret the result?
Okay, well, that's actually quite a good question. So, you know, you can do perfusion imaging at baseline, but if a myocardial segment is contracting and thickening normally, then resting perfusion is going to be normal. So it probably is not going to add an awful lot. And if you see normal contraction at baseline and you think you're seeing a perfusion defect, it's almost certainly an artifact and is not genuine. But if you've got a wall motion abnormality, in particular the myocardium's thin, coupled with a perfusion defect, then that's an infarct or irreversible ischemia. So it has some value. Probably the biggest value is making sure you've got the machine settings right and you've worked out what the administration level is going to be and you've got everything set up, because you don't have that much time at peak stress to do it. So that's probably, from a practical point of view, the biggest value of it.
Yes, and also I think there's another major value of doing perfusion at rest is if there is a wall motion abnormality.
Yes.
And if there's a good amount of perfusion, then it is a viable muscle.
Yep.
We make a diagnosis of myocardial viability even without giving dobutamine.
Well, I mean, we didn't. You're quite right, Roxy, and we didn't talk about that because, of course, if you see contrast within the myocardium, it implies microvascular integrity. And the microvasculature is not going to be complete if there isn't myocytes to supply.
Exactly.
So it's a very, very good marker.
Indicator.
And what we do, I don't know about you, but in very, very high risk patients with very, very poor LV function, when we're asked to get viability information, I actually don't bother with dobutamine. I just do it off the myocardial contrast echo. And our interventionists and surgeons are quite content with that.
Okay. Right.
It's an almost overwhelming number of questions, isn't it? So.
Okay. Okay, very quickly now. Okay, so this is a question. I think some of the questions actually we've answered as we were talking about.
Yeah.
So another question is, can we use strain imaging during contrast echo?
Well, actually, I think it's quite difficult because whilst there's been some attempts to do it, and I know that actually right at this moment, there is some software and technology which actually harnesses the effect of contrast to improve the speckle detection within the myocardium. Generally speaking, on most vendors' machines, actually contrast interferes with the speckle tracking and actually prevents you doing strain imaging. So, you know, at this moment in time, on most machines, it's not possible. But I have seen some software and some technology which actually seems to suggest that actually in the future we will be able to do that and it will improve it. So,
you know, absolutely. In fact, we are doing some work on this, and in fact, we found some very good results with low MI imaging, which is very interesting. With low MI imaging, when you flash and when the myocardium becomes dark, the endocardium becomes very clear.
Yes.
You get a very nice speckle tracking. Then once contrast comes in, then the speckle tracking goes all over the place.
Yeah.
So we've done a study on about 50 patients, but I think more study needs to be done. You quite rightly said it needs to be more defined.
And you know, the other thing that sort of, is you saying that reminds me that one of the things that I think that happens is when you see a subendocardial perfusion defect, so you see that dark rim,
Yes.
it actually helps you read wall motion. So,
Yes.
you know, you've got the perfusion
Yes.
information, which is great in itself, but
Yes.
in addition, you've got enhanced appreciation of wall motion abnormalities.
Absolutely. I mean, it enhances the perception of wall motion once you see the perfusion defect.
Yeah. It's actually a question here I've just noticed, Roxy, just
Yes.
to clarify that on that patient I showed who had the wall motion abnormality, sorry, who had the stomach pain before they got the wall motion abnormality.
Yes, with the left bundle branch block.
Yeah, so someone has asked, you know, why did the patient experience pain before the wall motion abnormality? Well,
Yes.
you know, this takes you back to that ischemic cascade.
Yes.
So actually, pain and ECG changes are actually one of the last things that
Yes.
happen.
Yes.
So you wouldn't expect that necessary to happen, but clearly the patient was getting a perfusion abnormality.
Yes.
Because we saw that
Yes.
on the contrast echo. So
Yeah.
that's why, you know, just looking at wall motion alone isn't perfect. It's better than ECG, but it's not
Yeah,
perfect.
absolutely. Here, the pain actually suggested the patient might be having ischemia, but the wall motion didn't actually show that.
No.
Because as you've quite rightly said, as we all know, with left bundle branch block, it's difficult to appreciate wall motion abnormality, but there's a way to look at it, isn't it? If you look at wall thickening
Yes.
and play frame by frame, you might be able to say that, okay, but it's difficult.
And
no
I,
question.
you know, I think had we been able to push that patient to a higher dose, we probably would have seen that quite nicely.
Yes,
So,
yes.
yeah.
Right. So, another very interesting question. What is the cost in euro for contrast study and in comparison with myocardial SPECT?
Oh, I'm not sure I know the answer to that question, Roxy. You probably know better than I do
Okay, I mean,
the relative costs.
essentially, I mean, I think cost, you know, we should look at cost not just as an upfront cost. We should look at the cost which results in doing the test in terms of downstream cost.
Yes.
So giving contrast, of course, it increases the cost. But we've done a study with exercise echocardiography and exercise ECG, where we use, as we know, we use contrast very liberally in 80–90%. So in fact, most of the studies were done with contrast. And when we looked at the downstream cost, the cost of stress echo was cheaper compared to stress ECG.
Yeah.
And stress ECG is the cheapest technique.
Yeah.
So if a technique with contrast is cheaper than stress ECG, how cheap it can be.
Yeah.
So essentially it answers the question that even though the upfront cost may be higher with contrast, but because you're getting more accurate result, you're not repeating the test because you're getting good data on your stress echo, and you're confident of normal and abnormal abnormalities, so the patient is being managed correctly.
And when you look at the overall cost of doing a stress echo, you know, an expensive machine costing 150,000 euros,
Yes.
you've got probably 2 staff in there.
Yes.
They're very highly paid, and and so you know, just the stress echo itself is
Yes.
not cheap. So the contrast component of that, I think, is relatively small.
Relatively small.
But the benefit you get out of it is huge.
It is huge, yeah. So cost effectiveness is much higher with contrast.
Yeah.
Okay, I think we've got just a couple of minutes, and I will choose another question. Okay, I think, you know, let's choose a question which is clinically important. So here's a question about protocol to use in heart failure patients. How high to go with dovitamin dose in terms of safety?
Well, that's the important thing. I mean, the most important thing, it's a diagnostic test at the end of the day, and we want to be safe.
Yes.
So you know, I always say, and it's a question that comes up time and time again, go very gingerly, very carefully, watch the patient's blood pressure, watch the patient for any symptoms, and also think about what the information you're getting out of it. So it may be just a viability question in a heart failure patient, and often it is. So, you know, you're going to do a low dose study, and I watch it very, very carefully. So as soon as I've got the answer, I stop. So as soon as if it's viability study, as soon as I've seen some evidence of increased contractility and myocardial reserve, then I stop. So, and that can happen at 5, it can happen at 10. So there's no value in going on now. If the question is, is there reversible ischemia? Then sometimes you do have to go a bit higher. But again, I would have a very low threshold for stopping if the patient got any symptoms or if they demonstrate ischemia. But if you're watching very, very carefully and watching for ischemia, then you can stop earlier on. And of course, the other thing you need to be careful of in these patients is if they develop an arrhythmia. So, if you start to get a lot of ventricular ectopics and runs and things like that, I personally would stop.
Yeah, and here, of course, again, vasodilator stress comes in very useful with contrast, because there, the side effect profile is much better than dobutamine in heart failure patients. Again, we did publish a study on series of heart failure patients with vasodilator MC, and it worked very, very well.
Yeah.
So that can be also introduced under such circumstances. Okay, I think we have now run out of time, and so I would like to now close this session by reminding you some of the key messages for this for the daily practice of the audience. So contrast must be used if two or more contiguous segments are not visualized. Care must be taken so as not to attenuate any part of the LV, and LV opacification should be uniform during acquisition, which is key in stress echo. And protocols used to assess wall motion with contrast allows simultaneous myocardial perfusion assessment, which actually improves diagnostic accuracy and outcome prediction, and it is now in the guidelines for stable angina. So we hope you enjoyed the time with us. Mark, thank you very much for your presentation. But the webinar, again, you can see it in a few days on the ESC website. And I must thank Bracco for sponsoring this webinar today. So thank you. Have a nice weekend. Goodbye.